So moving on to the pediatric part of the asthma, reactive airway disease protocol. This one, uh, uh, title of the protocol changes COPD group because you don't really have COPD in kids. So if you have a kid that has a silent chest, and then like you believe it's like an asthma attack or uh, possibly croup or something of that nature. A silent chest is a pretty ominous sign that respiratory failure or respiratory arrest is pretty imminent. So those are patients you're going to want to treat pretty quickly when you're on scene, and probably get them through the hospital as fast as you can. Bronchospasm is usually accompanied with the following findings: wheezing, prolonged expiration, increased respiratory rate or respiratory effort. I'm sorry, severe agitation, hypoxemia. Suprasternal and substernal retractions, trapoding. So as far as treating these patients goes, again, your routine patient care stuff, wear N95 if you believe it's bioterrorism or possibly infectious in nature. EMTs, if you're running a BLS truck, request ALS intercept if possible, if you feel like it's necessary. If they have their own inhaler, you can help give their own inhaler. Obtain a pulse ox, oxygen titrated to SpO2 between 94 and 99. And then, if they need it, assist with their ventilations with a BVM and oxygen. If it's croup, provide humidified oxygen. We do have the humidifiers in the airway cabinets, and you just put sterile water in it. Breathing treatments, 2.5 milligrams albuterol nebulized. It's important to note that in pediatric patients, you don't add the Atrovent to the breathing treatment. But don't delay transport to administer these medicines. If they're really that sick, you need to transport as soon as possible. Advanced EMTs, make sure. Well, everybody really needs to assess circulation, perfusion, and mental status. Same thing for you guys, advanced EMTs. Do the albuterol. Don't mix the Atrovent. Just straight albuterol via nebulizer, and then IV access and fluids to maintain a normal systolic blood pressure. Paramedics, you guys can consider some salbutamol, 1 milligram per kilogram for kids for a severe exacerbation or a patient who doesn't respond to the first nebulizer. If the airway is not maintained by other means, including attempts at assisted ventilation or prolonged assisted ventilation as anticipated, consider intubating the patient. You should cardiac monitor these patients. Make sure you get a focused history and a detailed physical exam en route. And if they're still not responding after multiple breathing treatments, I would consider epi 0.01 milligrams per kilogram IM. Max dose is going to be 0.3. Or if they're unable to inhale the albuterol, you can also give the epi. The bottom of the protocol notes it is extremely important to reassure a frightened child. IV access should be reserved for situations when the IV is absolutely necessary to treat. So, advanced EMTs, paramedics, that applies to you guys. Don't start the IV unless you absolutely have to, okay?